And thank you. That's the title, obviously. And it's really to get some simple way to help the practicing clinician deal with an issue which has gotten a lot of attention lately, and I think in a certain sense has had a very adverse effect on the proper use of statin treatment. So anyway, this is sort of the 4 major take-home messages that I'll try to convince you about this evening. First of all, statins really decrease cardiovascular disease. They are really good drugs. They're one of the best drugs that have come along since I've been in medical practice. That really the benefits are amazing and the complications are surprisingly few. Okay, now it's now totally clear that type 2 diabetes will occur in approximately 10% of statin-treated patients. There's been several large studies pointing that out. Okay. And that, unfortunately, has attracted a lot of attention. And the result has been that the clinical benefits of statins, which really greatly exceed, and I can't do all that tonight, but really there's beautiful studies showing how beneficial their use in the proper setting is versus the adverse effect of the increased risk of diabetes. That it's a shame if we don't use them thoughtfully. And finally, and this is where I got interested in this, if we could find a simple way to know at outset who may get diabetes, then hopefully we could begin doing things right away that would be more clinically beneficial and decrease the risk associated with the advent of diabetes, which I'm not trying to trivialize, but I don't want it's gotten too important, I think. Okay, so this is a complicated slide, as you can see, and basically what it is just the results of multiple large-scale studies. These were studies when they were using statins in people to try to prevent heart disease, and they list, and if I can find that arrow, I don't even see it. You see, is there an arrow up there? Okay. You see this big line here? That big line there means whether you got better or worse. If the result, if that black square is to the right of that line, that means that the patients got diabetes, more diabetes. If it's to the left, it means they didn't. And as you can see, it's not, dramatic, but the average is about 10%. So this is where that notion of 10% comes from. But each study had different answers, and some actually didn't show any terrible effect. But I think in general, there'd be no reason to doubt that it happens. Okay, so that
says 100%, right?
No, that means all the studies.
I see.
I got interested in this. I knew about it, but I got a lot of things I'm interested in. When this paper came out, which was the first really good paper where a group at UCSF, the first author of UCSF, it was a worldwide study, went back and looked. Atorvastatin is one of the statins. It's Lipitor, which is a very big selling drug. And they reviewed 3 studies to try to see what was it that really predicted who got diabetes. The first time it was really done. And these are 3 studies, and those are the names, those are the trials. And the first population was patients who had a heart disease and a high cholesterol, and they used 2 different doses of statins. The second study, you had to have a prior heart attack, and this was atorvastatin, which is Lipitor in high dosage, and much smaller, a lower dose of simvastatin, which is another statin. And the last one was people who had strokes or transient ischemic attacks, and they had to have a cholesterol above 100 to 190. And at that time, if you were at high risk, being less than 100 was where you should be with your LDL cholesterol. So those are the studies that they analyzed. And the outcome was just diabetes. So all the people were in the study at the beginning that were analyzed had to be free of diabetes at outset. Then if they got fasting glucose above that number, which is the current sort of cut point for diabetes, or their blood glucose increased by at least 40 milligrams per DL, excuse me, these were somewhat arbitrary but reasonable, saying if you started non-diabetic and that happened, you could be considered to have developed diabetes. Now this is where it gets sort of messy, but I'll make it simple. So this is the first study. On the far left is all the things that one could possibly dream about that could increase the risk of diabetes. On the right, over there, the multivariate analysis. See if I can do better with this thing. I can't even see the arrow. Does anybody see an arrow up there? Oh yeah, I see it now. Okay, so these guys are all things that actually, when analyzed in sophistication, were statistically predictive. And what they almost always were, as you'll see, were glucose level, triglyceride level, hypertension, and a thing called BMI, which is body mass index, which is a measure of adiposity. So this is the first study, the first of those three, and it said that if you had those things, you were at more risk of diabetes. And this is the second one. It's called IDEAL. These cardiologists love these fancy names for their studies. I have no idea what they stand for. But you can see, not so easily, but you can see just by where they are, they're always the same things. And I'll show those some better slides in a moment, which will make that more obvious. If I could have a pointer, I could go to every one, but well, that's neither here nor there. And this is the third one. And again, it's the same thing as glucose, hypertension, triglycerides, BMI. Those are the four things that have been predictive. Now, this makes it much simpler. And here we're looking at now the first one, that TNT. And now we're looking at, on the far left, fasting glucose. The next one, triglycerides, BMI, and history of hypertension. And obviously, what this shows that in every instance, that with those four things, there was a statistically significant greater likelihood if you had one of those that you would get diabetes. And the hazard ratios, the risk range from with like glucose 2 or 3 fold HR. There's BMI 2.7. You can see his hypertension history was less, but all of those in that study were predictive, increased the risk if you had one of them 2 to 3 fold. This is the second study, and it shows the exact same thing. Fasting glucose, triglycerides, BMI, hypertension. Again, if you have any of those, your risk of getting diabetes increased by 2 to 3 fold. And the last one, again, the same thing. Well, that paper, when I read that, I said I was aware of the phenomenon, and it was interesting, but a lot of things are interesting. But when I saw this, then I really got excited, and this now gets very semi-personal. Okay, first of all, the blood glucose. If you look, they divided the people into quintiles. The 20% with the lowest glucose on the far left, the 20% with the higher glucose on the far right. Now look at quintile 3. If you see, those are people whose glucoses were fasting glucose, between 95 and 100, 95 and 100, are 94 and 98. And underneath in quintile 3, you can see in 2 of those 3 studies, that group began to have a statistical increased likelihood of having diabetes. Now look at quintile 4. Above 100, above 100, above 98. In quintile, these numbers are really arbitrary, but there's a term used that's called pre-diabetes. These are people who, because their glucose has not reached a high enough level to merit being stamped diabetes, are called pre-diabetics. And that ranges from 100 to 125. That is pre-diabetes. Now it's clear that essentially everybody in quintile 5 has pre-diabetes. 4, everybody pretty much, 5 for certainly, and they're even higher, 107 and above. So obviously having a high glucose, which just doesn't seem too surprising, if the diagnosis is having a glucose above 126, it doesn't seem too unreasonable to have a high glucose be predictive. But this was the first quantitative analysis of that. And it says that one could use a conventional term, prediabetes, that most clinicians are aware of that, to signify a subset of patients who are about to get statins who are at much greater risk to get diabetes. At least that was the implication of that, which was the first sort of big insight, I think, in what was going on. Okay, now this is what gets personal. When I was a young lad, it's like Gilbert and Sullivan, I can't sing, so I won't go any further than that. Our research group has spent a lot of time in the 60s and 70s convincing the world that the fundamental defect in what is now called type 2 diabetes is resistance to the action of insulin. And if you cannot make more insulin, you get type 2 diabetes. And that's what type 2 diabetes is. Insulin resistance and the inability to compensate for the defect by pushing glucose in the cells by having higher insulin. Okay. Then later on, I realized, and didn't think other people were quite aware, but that most people who are insulin resistant were secreting large amounts of insulin and not getting diabetes. So the vast majority of people who could qualify for the term insulin resistance don't get diabetes. They do secrete large amounts of insulin, and that compensates for the defect in insulin action. But they are likely to have some degree of glucose intolerance, prediabetes, in other words, could be, hypertension, a high plasma triglyceride concentration. And these were exactly the things that in that first study persistently was what predicted type 2 diabetes. So since this was something that I had lived with, I thought, wow, let's go ahead now and try to get more information about how to think about this. Okay. Syndrome X was the title that I used to describe this cluster, which is a major cause of coronary heart disease. If you ask, this is sort of parenthetical, but if you asked who gets coronary heart disease, there's really 2 large clusters. One who have they have a high LDL particularly, that's what they have. The other group are these people here, and they have a different pathophysiology. So let's go ahead that anyway. So the name Syndrome X was the name I applied because, as I was telling Nora Kane, I went to a school college that didn't believe in mathematics, but I did know that X was the unknown because that was my algebra from high school. So and this was an unknown syndrome. I called it Syndrome X. Okay. It also, when I saw that, is I realized that something we had done a long time ago was very relevant to this issue. When people were doing studies, these big clinical studies, all they cared was, do people have a high LDL cholesterol? Now, it turns out that people who have a high LDL cholesterol alone are very different from those who have a high LDL and a high triglyceride. And again, this gets very, goes right back to what we've been seeing. Oh, thank you, Nora. Frank Sinatra, this is gin. Don't let her fool you.
Sorry.
So I remember we had done a study many years earlier, and this is the result of that study. And these words are old words. Control just meant people who had a normal LDL and a normal triglyceride. Type 2A, which is an old descriptive word, were people who had only a high LDL cholesterol. Type 2B had a high LDL and a high triglyceride, and type 4 had just a high triglyceride. And as you can see, well, the bars are around that makes the difference. So we look down at type 2A, the triglycerides are like 100 milligram per deciliter, and the people with type 2B are more like 300 or something. These are millimoles, but I made a quick conversion. So basically, those are really important differences. The LDL, their cholesterol wasn't all that different. So they're really, these two groups are different because one, they both have high LDLs and require or should get statins, but one group has a high triglyceride as well. Now this is a glucose tolerance test of those same people. See, this is 1993. This was a few years ago. And so on the left is the glucose concentrations, and on the right are the insulin concentrations. Now, the group with type 2B has the highest glucose, as you see, and the highest insulins. So they are, and you can predict, are should be insulin-resistant people. So that's the group with both high LDL, high triglyceride. Type 4, which is just high triglyceride, was second in each of these things, and they get heart disease too, but that gets, I don't want to go into that for the moment. We'll stick with the high cholesterol. Then we go down to the next group, which is the control. And if you notice, the type 2A, pure high cholesterol, only a high LDL cholesterol, were the most normal. They were more normal than the people who had neither a high LDL or a high triglyceride. My colleagues wanted to make a big fuss about that at the time, and I thought that was pushing it a bit, so it wasn't essential to what we were doing. But it gets more interesting now because it turns out that people who have a disease called familial hypercholesterolemia, very high cholesterols, actually have less diabetes in the world at large, which is sort of fits in with that, but that's a different story also. So this again emphasizes that in these clinical studies, you don't have a homogeneous group with just high cholesterol. They're heterogeneous. Some high cholesterol plus high triglycerides. So that got us really interesting. Now, this is something I have to spend a little time on, and I apologize, but it's sort of something also we introduced years ago to quantify how insulin resistant a person was. So what we do was do a 3-hour infusion, 3-hour intravenous infusion, giving glucose and insulin and a drug which actually inhibits the ability of the pancreas to make insulin. So we have chemical pancreatectomy that lasts as long as the infusion goes on. So what that means is that after a couple hours, everybody has the same steady state plasma insulin level in their blood. We've suppressed their insulin, we've given them insulin, same amount, so they have the exact same level. We're also giving them the same glucose challenge, and they eventually get to a steady state plasma glucose level. Well, if the insulin level is the same in everybody, and what insulin does is put glucose away, and you're giving the equal amount of glucose to everybody, if everybody were equally insulin sensitive, they would have the exact same steady state plasma glucose concentration. Insulin's the same, glucose coming in is the same, you should be the same. The higher that steady state plasma glucose level, the more insulin resistant the person. Well, this goes, you can see this is a long time ago, straight from the manuscript. And on your left are the studies we did in that same group of people, control to a high LDL, to B high LDL and high TG for just high TG. Again, we achieved our goal, exact same insulin levels in everybody during the study. On the right was how high their glucose went. And as you can see, control in 2A, the people with high LDL cholesterol look just like they're as equally insulin sensitive as are the group who has normal cholesterol and normal TGs. 2B, high cholesterol, high TG, 2 to 3 times more insulin resistant. So now we have a group that's getting these statin drugs to lower cholesterol, which are totally homogeneous. Totally heterogeneous, totally different. You have people only high LDL, some people high LDL, high TG. And that has to be of some interest since we know that this insulin resistance is what leads to diabetes. So not half, but a substantial number of the people already we know are more likely to get prediabetes in a conceptual way. There's no question about it. It just, they're more insulin resistant, they're more likely to get diabetes. So we decided that study back here was done in 1993, and it was a time when I was doing a lot of research in Taiwan, and these are actually Taiwanese, and so now it's not 1993, and I don't think Taiwanese are that different from anybody else, but we thought we'd do it again, and we took some people that we had to study, and on the left are people who have a triglyceride which is high, above 150 milligram per deciliter, which is basically the cut point that people use. And on the right, people with a low triglyceride. Okay? And again, they're the same age, same general distribution. They were heavier in general. We said earlier the BMI, high BMI, predicted diabetes. It makes you more insulin resistant. And those people with the high TG had a high BMI as well. They both had high cholesterols. Then obviously only one group had a high TG. The group that had the high TG was twice as group with a low TG. So we had two groups which were pretty similar in all respects except for their triglyceride concentration. And their fasting plasma glucoses weren't that different. Now, NGT stands for normal glucose tolerance. IFG, let's take NGT first. So you can see of the people who had the high triglycerides, 40% had normal glucose tolerance still. Of the people who had the low triglyceride, 70% had normal glucose tolerance. So again, if you had a high triglyceride, you were much more likely, or much less likely, to have a normal glucose tolerance. And the IFG is another part of the thing called prediabetes. That's isolated fasting glucose. These terms are irrelevant. IGT is impaired glucose tolerance. those three categories, IFG and combined IFG and IGT, all comprise this thing called prediabetes. But that's what the American Diabetes Association got very fancy with these three subheadings. But the important point is that the people who have the high triglycerides are much more likely to have some degree of prediabetes or glucose intolerance. Down here, the last line, are the steady-state plasma glucose concentrations. And it's very clear that people who have high triglycerides had a higher level, they're much more insulin resistant. So again, we're emphasizing how different, potentially different, are the total group of people who are getting statins to lower their cholesterol. Then a colleague at UCSF, who we've done work with more recently, said that, well, going back to those, remember I said there were three studies to begin with. One was TNT and one was ideal. She went back to those studies and she found that 39% of the people were pre-diabetic at baseline, and type 2 diabetes occurred 7 times more commonly in the pre-diabetic population. So this was now the first suggestion that one could, by one simple measurement, just glucose, pretty well begin to stratify this population into two very different risk groups for type 2 diabetes. Well, that was good. That was a good beginning. But as I said 2 slides ago, there are a bunch of categories of prediabetes, and prediabetes itself is not homogeneous, as I'll show you right now. So this shows that people with prediabetes are heterogeneous in terms of the risk of being insulin resistant. And again, it's insulin resistance that we're focused on because that is a basic element that you have to get type 2 diabetes. Well, this is a study that we've done recently, and it's a fancy slide for a change. I probably could even show no, I probably can't. Anyway, so this is a measure, again, of insulin resistance, this SSPG, direct measure of insulin resistance, not an estimate, direct measure, and the higher, the more insulin resistant. So over there are NGT, normal glucose tolerance, and then there's isolated fasting glucose, impaired glucose tolerance, and combined. And as you can see, that they have the last 3 groups, which are the pre-diabetics, are very different. That IFG, which is the most common pre-diabetic group, is much more insulin sensitive than people who have both IFG and IGT, almost 10 versus 16. Okay, so if it's heterogeneous, what can you do, to try to make this more sensible? And this is just somebody else's study. It's the opposite way of measuring insulin resistance. So in this case, the lower, the more resistant, but it shows the exact same thing, that IGT and IFG, these 2 subgroups in prediabetes, are quite different. So if you just look for prediabetes, that'll be terrific, because clearly you'll enrich the pool of people who are going to get diabetes. But if you could also figure out how to take the prediabetes part and make it more specific, then that would be a great idea. Well, it turns out, as I've been talking about, that having a high triglyceride along with a high LDL made it much more likely that you would get diabetes, that you would be insulin resistant. So we did something very simple and took people back to these same basic studies, and we divided them into 4 groups, thinking with this idea. So if we actually, these are all semi-arbitrary, but it turns out that if you're normal glucose tolerant, about a quarter to a third of the patients will be sufficiently insulin resistant and hyperinsulinemic to get a lot of unfortunate clinical syndromes. Heart disease, polycystic ovary syndrome, bad liver disease, etc. If you have IFG, which is one of the pre-diabetic categories, 57% are insulin resistant. So obviously you're increasing your yield. If you have the combination of those two, it's 94%. So again, emphasizing that putting all what's called pre-diabetes into one category can be very misleading, or it makes it much less precise. And so what we did was to go ahead and we now did 4 things. We took people, NFG, and a normal triglyceride, that's the far left. Then normal fasting glucose and a high triglyceride, which we predicted, and as you see, that's the SSPG concentration, and it's definitely higher in the people who have equal glucoses. They both have normal fasting glucose, but one has a high triglyceride. Now we have prediabetes by itself, but with a normal triglyceride. And that's bad too, but that's, we knew the prediabetes makes you more insulin resistant, but it wasn't not that much more powerful than having a normal glucose and a high triglyceride. And the ultimate was to put them both together, prediabetes and a high triglyceride, and you're much more insulin resistant. Again, measuring it in that technique I showed you. So this now we're trying to even refine a very simple way to identify people at risk for type 2 diabetes. Well, when we then used those 4 groups, those 4 categories, we went back to that initial study, and those are the 4 groups, very simple. And then we said, okay, if we just look at this prospectively, what do we see? And this was astounding to me. On the far left and the lower bar, you see where it says no prediabetes. And the first one, the triglycerides are on the vertical axis, and whether or not you have diabetes are on the horizontal axis. So as you can see, there's a very small little tower, which are patients with no prediabetes, normal fasting glucose, and normal triglycerides. And they get almost no diabetes. In fact, I can tell you that they are no more at risk taking statins than are people who are taking no statin, the placebo group. So about 1/3 to 40% of people who are non-diabetic now, who we put on statins, are unlikely to get diabetes. No more likely than just being alive, because placebo group is the same value. Right behind that, no prediabetes, but a high triglyceride, and you double your risk. So okay, you're not as bad as you could be, but you're already worse by having one abnormality. Now look at the pre-diabetic group, and that's the blue bar on the right, and now you're up to 12% of the population getting statins will get, if you have those characteristics, a pre-diabetes and a normal triglyceride, about 10 or 12% of you will get type 2 diabetes. Now, if you have both of those things, we're now talking about 20%. So one can, with the simplest ways, 2 standardized, simple measurements, before you ever give a person a statin, you can say, okay, this person is at very low risk, this person's at a high risk. Well, why do we care? Well, why should one care? Well, for very good reasons. For example, if a person is at very low risk, you would follow their glucose for sure, but fairly casually, maybe every year or something, while they're on statins. if a person had a very high level, a high TG and a high and pre-diabetes, first of all, you'd be a lot more careful. You'd follow them a lot more closely, and you would begin to do interventions that will make it less likely to get diabetes by repairing or improving the insulin sensitivity. For example, one more slide. This just shows the prediction of those four, things. So, you can see as you go up, your chances of getting type 2 diabetes are just getting worse and worse and worse and worse. Very straightforward. But to sort of summarize, the development of diabetes with people getting statins will vary dramatically as a measure of their glycemic measurements and their triglyceride measurements. I mean, skin, simple clinical tools. Having either one increases the risk of statin-induced diabetes. Having them together is much worse in people who are high risk. It doesn't mean they should not get statins, and that's crucial. Even in that population, they will benefit. A frank diabetic benefits from getting statins. But there's no reason to try not to prevent that from occurring. So if you have that information before you start the drug, again, as I was saying, you can begin to do things. Not only would you follow these patients more at different levels of carefulness, because they have different risks, and that would be sensible, but there are ways that you can, let's not talk about that yet. Yeah. Again, let's make sure I am. Yeah. For example, this is the ideal, it's so crucial. So in the one study, it was very clear that the more weight you gain, the more chance of getting diabetes. Well, again, the more at risk you are, already you're insulin resistant, the more weight you gain is going to make it even worse. So if your people, the patient you're talking to already is pre-diabetic with a high triglyceride, then certainly you would do the best thing that you could possibly do to help them lose weight, to help them increase their activity, to do a more intensive weight loss program, all the things that you would do to try to prevent diabetes. And it's been shown that there are data that have been published looking at the thing called the diabetes research, DRTC, I remember it was for, which showed that taking non-diabetics and just lifestyle changes can reduce the risk of diabetes. So knowing who's at risk, you can begin to reduce the risk. There are unanswered questions, and this is where we're at now. For example, we have no idea, really, what is the turning point. I mean, do statins themselves, do they have any direct effect on making insulin resistance worse, making insulin secretion impaired? There are no good data at all to understand, to explain why that happens. And the other thing is, does the glucose go up? Is it the fact that if you're already bad, that statins do something bad to everybody, but if you're really healthy to begin with, the bad is not so bad. And if you're pre-diabetic and have a high TG to begin with, the bad will really toss you over into the brink. And we don't know that. There are very little, most of the data we have about this problem come from big trials with no mechanistic studies. So having gone through all this and got these tools, one of the things that we're trying to do now is to do studies to see answer those two questions particularly, the first one particularly, what is the defect? What do statins do that leads to diabetes? And one of the reasons I was coming tonight would be to hope to convince you, or not convince the wrong word, if anybody was interested in volunteering for some of these studies or know people who should be taking statins who are not taking statins because they're afraid of diabetes, etc., we would be obviously very interested in having volunteers for our research studies. But hopefully even this information alone may be of some use to you. We have tossed out some flyers there, and I'm happy to take questions now, if there are any questions.
Do we have any questions? Here, I'm going to give this to you.
Oh, I speak very loudly.
I know, but it has to be on the tape.
Oh, yes, okay. Let's see, I forgot my question. Yeah, you had that list in the beginning of the factors, and I believe you said any one of them could increase the risk. But then there was a lot of time spent on the high triglycerides and the high pre-diabetic. So is that a greater risk? Like, let me give you an example. I'm overweight, but my triglycerides are okay, and I'm not pre-diabetic. So am I at a lesser risk, even though I'm overweight?
Yes, that's funny because I'm involved in a paper right now. This is one of the interesting debates because there are clearly people who are overweight, who are normally metabolic. They have no metabolic risk factors for anything. And as long as that's the case, they are no increased risk. On the other hand, the longer one's overweight and the more, there's two things going on. First of all, there is a clear-cut genetic regulation of insulin resistance, which accounts for, some people are just born, there are even racial differences in insulin resistance, for example. So you have that. Also, fitness is very important. So the more fit you are, the more insulin sensitive you are, the more sedentary, the more insulin resistant you are. So, but in generally speaking, the longer one is overweight and the more severe the degree of weight gain, which also I'm sure ends up with a more severe decrease in activity, the more likely you become unhealthy. But at any given moment, there's maybe a quarter of the world that can be overweight and at that moment in time are metabolically quite healthy. It doesn't mean it stays that way forever, but it means that, no one knows how long it stays, for example. But the heavier you are and the longer you're heavy, the less likely you'll be free of trouble.
I think you've convinced us that statins are useful, even if there is some implication of diabetes.
Yes.
Now, some of us take statins,
Yeah.
and I've been taking them for a long time, and now my glucose is starting to go up. The question is, should I ask the doctor to decrease, not totally lose the statin, but could we start checking to see what level can we reduce it?
Yeah.
I take now 40. Should I go to 30
Of which
units?
one? Atorvastatin? Or?
Right.
Oh, well, I don't want to be a clinician up here, but because that's not fair. I should not try to do that. It's not one of the things that's even less clear than the things I mentioned is there a dose response? That's not so clear to me. That means not so clear, not to me, but in other words, it's not so obvious that going down would be helpful. What would be more helpful might be to think about, things like more activity, dietary changes, etc. So the notion of decreasing dose, obviously one should get the lowest dose of any drug you're taking for any disease that does this job. But the idea that you're going to necessarily improve diabetes by lowering dose, I don't think the evidence is very good for that. It's not terrible, but it's not good. So the dose issue, in fact, I didn't go into it, get too complicated, but the first few slides I showed In some of those studies where they were doing, different doses, they could not see a big difference. Although there's some studies that have shown it, so I say it's a murky field, but much more successful would be to do other things which we know will decrease risk of diabetes.
Okay.
And more activity.
Yeah.
Have any studies been done to show the influence of A1C versus the fasting glucose on the risk factors?
No, I think they're pretty much. I'm not a great believer. I think they have different goals. First of all, the criteria also include A1C concentrations, and I think that there are too many instances in my mind where the A1C is regulated by other things beside just glucose. Age of blood, how long the blood survival time is, how proportion of new red cells versus old cells. So by and large, they give you the same story, but I actually feel more comfortable personally using A1C levels are very good as the clinician in the sense that it gives a much wider view of the usual glucose concentration over a period of time. But in terms of cut points and to make decisions about, I actually feel that fasting glucose are more closer to the issue. That doesn't mean the A1Cs are not useful, but I don't think they change anything I said, for example.
Do any of the studies show a time dependence for people who go on statins and develop high blood sugar, and then after a number of years it goes back down?
Unfortunately, it's not. I would say that 85% or more. This is obviously off the cuff. Of the data are just simple clinical studies, cholesterol lowering and coronary heart disease. So how effective is it to lower cholesterol? How lower should the cholesterol be, etc.? So people have not looked at this, but recently we've had a case at Stanford which was very interesting, where the person had a very sudden onset of hyperglycemia, not clear why, while getting statins. And when they stopped the statins, this person's wasn't as, this was a very relatively acute, in a couple of weeks or a week, I can't remember exactly because wasn't my patient, I was just being asked some questions about it. There was a fairly prompt and sudden increase in glucose. And when the statin was stopped, the glucose fell. It fell pretty promptly, but it's pretty clear that this person is almost certainly, if not pre-diabetic, now mildly diabetic. In other words, it didn't all go away, as I'm trying to say. But there was no question that when statins were started, there was a sudden increment in blood glucose. It's very quick, which is not the common story. Yes, I can't see.
I've got a lady here with the mic. Go ahead.
Okay, just talk. I can't.
Yeah,
Oh, I'm sorry.
you mentioned that if you have a high triglyceride, that would lead to insulin resistant.
No, I didn't mean to say that. I meant that it was a marker of insulin
It's a
resistance.
marker of insulin resistant. So, but I guess the doctor had said that there's fibrates or whatever that lower.
Fibrates, yeah.
Yeah, he said it does. There's no studies that show that it does any good. So I'm kind of confused by that.
Well, there's two different issues mixed up here. A high triglyceride, by and large, is because the patient is insulin resistant and has high insulin levels. The insulin resistance results in more fatty acids leaving the adipose tissue, and the insulin increases the conversion of those fatty acids to triglyceride. So there's an intricate thing which, because of the insulin resistance and hyperinsulinemia, you have high triglycerides. If you lower triglycerides, do you reduce heart disease, which is the fibrate story you brought up? And it's not so obvious. That's been argued back and forth. I think this sort of people believe now that triglycerides can help reduce heart disease, but it's been hard to show that. But that doesn't deal with the idea that triglycerides are a marker for insulin resistance, and lowering triglycerides by an unrelated method, which what fibrates and do, is not going to affect insulin resistance. We showed that some time ago. You may have a lower triglyceride because you're doing other things, but you're not improving insulin action. So in terms of, in this way, the way I'm using triglycerides is simply to say that it's a marker. So the idea is, can we get simple markers to help clinicians decide who's at most at risk to get diabetes? So they can help them in terms of how they go ahead. So for example, gentleman here, if he had done this, if that had been done, and he was shown to be at risk, they might have started things much earlier, to try to help him lose some weight, help them make it a little more active, make it less likely to get it. In other words, the whole idea is simple-minded things that can be clinically useful and beneficial to decrease even the additional risk of statins, so people don't stop using them. So triglycerides are a marker. Triglycerides don't cause insulin resistance, other way around.
Can you speak to the estimator that many of the doctors use, that has been the predictor for when to start statins? It has the factors of hypertension, diabetes, what your cholesterol is, and your age. And it's an app that they all use, it seems. And if it's a certain percentage, they start you on statins, and I was resistant to that.
What's the question?
It's called an estimator.
Oh,
and it's an app that they use.
That's fine.
They're not including the things you talk about, the
because they
triglycerides
aren't
and the
even
glucose.
thinking about the diabetes. They're thinking about reducing LDL cholesterol.
Yeah. And the question on the estimator is, do you have diabetes or no?
Yeah.
That's the only.
Because that's a risk factor for heart disease. It's not. They aren't at all interested in the risk of getting diabetes. What they're trying to do, for example, if you have diabetes, you're more at risk of getting heart disease, so your LDL cholesterol should probably be more aggressively lowered than someone who's not. So that's how they're using it. And diabetes would just make it, for example, I think if you have diabetes, they want under 100 or versus 130. If you're not diabetic, I can't remember all of those cut points, which I'm not such a great believer in. But it's a whole different process. They have no interest in statin-induced diabetes or statin-associated diabetes. They're trying to figure out, given your risk for heart disease, should statins be started? And what worries me is that it turns out now that people who do get these risk, things, a lot of them are not getting statins because of the fear of diabetes. And so our effort has been to try to show that you can't prevent it, but you can understand who's likely, and then you can try to modify behavior and your intervention to reduce the adverse effects of that.
Yeah, back to something you said before the last question that I'm not sure I understood.
Yeah.
I'm way out of my league here on medical information, but did you say something about the triglyceride is the marker for insulin resistance?
Right.
But there's also the element of the excess insulin, and that you could reduce the excess insulin, but your resistance wasn't going to change?
No, well,
Okay.
let's put it that way around. The basic defect, this gets really complicated now, but the problem is insulin resistance. I mean, that's the basic physiological defect. For whatever reason, we've evolved to really want to maintain our glucose normal. Why do we care so much about maintaining normal glucose? You know, I wasn't around when all this was decided. But that's we do that. So we'll secrete as much insulin as we can to maintain normal glucose. Now, it turns out that there are tissues in the body. Insulin resistance doesn't involve every tissue. So there are tissues in the body that are insulin sensitive. So, for example, I'm insulin resistant. I don't want diabetes. I'm secreting lots of insulin. Fine. The insulin, my kidney is insulin sensitive, and the kidney insulin makes you retain sodium. So that increases my risk of hypertension. So some of the bad things come from the compensation we're making for our insulin resistance. But in terms of the triglycerides, I just was trying to say that lowering triglycerides won't make you more insulin sensitive, because the high triglycerides didn't cause you insulin resistance, the other way around. So if you lower triglycerides, that's great, probably good for you, but it's not going to make you more insulin sensitive. I'm not sure I answered your question.
Yeah, I guess just to use me as an example, I used to have high triglycerides.
Yeah.
Now I don't. So does that mean I'm not pumping out the excess, but I'm still insulin resistant?
Well, that would be very interesting to know. It would also depend, have you changed any dietary thing at all?
Oh, it's been years.
Oh, because, for example, if you're insulin resistant and you eat a diet which is relatively low in fat and high in carbohydrate, your triglycerides will go up because you have to secrete more insulin because you're eating more carbohydrate. If you do it the other way around, your insulin will go down. Your insulin resistance hasn't changed. So a lot of the insulin level will depend upon what you're eating, et cetera, but the basic defect, so changing diet can lower triglyceride or increase it, depending upon, which way you go. But it doesn't necessarily, if you're not losing weight, change your insulin, your basic defect is still there. You're just being able to manipulate it by nutritional modulation.
I think that's probably our last question.
Have you written this up somewhere so we could get it and read it maybe somewhere? Or?
Well, the last paper, this is really pretty, as I said, most of the time I wasn't interested, I knew about the stuff but didn't really care until it suddenly was part of my, things that I invented, so I really wanted to get into it again. Things that I really was interested in, I wanted to get into that again. But so that paper, are the slides still on?
It should be if you go back.
Yeah.
Even by Cohen?
That paper is not out yet. It's out in PubMed, so if one can get it, but it's not even it's not even in the journal mailed out yet, but one can find it.
You can certainly find the abstract, and is it in pre-pub online?
Oh yeah, the whole paper's there.
And the electronic.
Yeah, there's an electronic version there.
Are you the senior author on that one? Or?
Well,
Are you the senior author or somebody else?
I'm the last guy.
We could find it.
Okay.
We could find it.
Now, there's two first authors. The first author is this woman, this one back here. Oh, where's her name? I'm sorry. Her name, yeah, and Josh Knowles, those are the co-authors. Josh is from Stanford, one of my colleagues. And I'm the last author.
We can get that, yes. I think we're gonna wrap it up. You want to ask a question afterward? Because we're out of time. So I would like to thank Dr. Reaven and all of you for being here tonight. Thank you.